Good morning. Standing before you now is the shadow of Dean Steifbergen because she has no voice. So the words you are hearing now are Dean Steifbergen's, who wants to welcome you to the Jack and Laura Lee Blanton Lectureship in Nursing, which was established by a pledge from Mr. and Mrs. Jack S. Blanton Sr. from Houston, with matching funds from the Regents Endowed Teachers and Scholars Program, and approved by the Board of Regents on December 4th, 1986. Mr. Blanton, an active civic and business leader, holds 2 degrees from the University of Texas at Austin, a BA in history, and an LLB from the law school. In tribute to his long-standing commitment to the university, Mr. Blanton has received the Distinguished Alumnus Award and the Santa Rita Award. In addition to serving as chairman of the Board of Regents from 1987 to 1989, Mr. Blanton also served as chairman of the Houston Endowment and the Greater Houston Partnership. Mr. Blanton has spent his career in the oil business and is now president of Edie Refining Company in Houston. Laura Lee Blanton also received a BA in history from the university and served as an honorary member of the School of Nursing Faculty Advisory Council. Mrs. Blanton, who died in 1999, is remembered for her strong support of the School of Nursing as well as education and cultural arts. The Jack and Laura Lee Blanton Lectureship in Nursing is a public forum to address the critical issues facing nursing today. And now, it's my pleasure to introduce Sharon Horner, who's going to introduce the speaker. I am Sharon Horner. And it's my pleasure to introduce our speaker, who is Dr. Nancy Mccain. Dr. McCain received her bachelor's and master's from the University of Mississippi. And as a new master's prepared nurse, she became a faculty member at the University of Mississippi, so something that some of you may have noted in this school. And at the same time, during that time, she did take a leave to go work at the University of Alabama in Birmingham on her doctorate. She has risen through the ranks from instructor to assistant professor and then to associate professor at the University of Mississippi, after which she moved on to the Medical College of Georgia, where they were launching their new doctoral program, and she has the dubious distinction of having me in her classes in the new PhD program. She left medical college to complete a postdoc in Dr. Zeller's T32 project that focused on nursing care of persons with AIDS. After completing the postdoc, she went to Virginia Commonwealth, where she was extremely successful in obtaining a series of R01 grants that focused on psychoneuroimmunology-based stress management intervention in HIV disease and now in breast cancer. Her work is consistent with the NIH's roadmap of melding behavioral and biological approaches to addressing health problems. She's an excellent researcher, a great teacher, and a wonderful colleague. Please join me in welcoming Dr. Nancy Mccain.
Thank you, Dr. Horner. Thank you. I appreciate that introduction very much, and it is of a special significance when you probably, all of you have probably heard the stories that one of the best rewards in teaching is to have your students exceed you and lead the way in science, and Dr. Horner has certainly done that. It's particular pleasure that you mentioned that, Sharon. We were at the Medical College of Georgia and had a great time. I had a great time. Yeah, she was a great student and now a great scientist. So I'm very pleased to be here for the Jack and Laura Lee Blanton Lectureship in Nursing. I was able to pull this slide off of your website and with some little magic from the PDF program, I was able to copy, I'm sorry, wrong button, your logo here. What starts here changes the world, and I was just fascinated with that logo. I do believe that that's the mission of a university, you know, starting people towards changing the world, changing society. So I'm really entranced with that. So I'm very appreciative of the offer to be here with you. So I was invited to talk with you about advancements in my area of research, biobehavioral clinical research broadly, My postdoctoral work with Dr. Zeller in Chicago was focused on psychoneuroimmunology. I did at that time work with people with HIV infection, but Dr. Zeller is a psychoneuroimmunologist, and that's where my focus has been. I have the luxury now of being part of a P30 Center for Excellence in Biobehavioral Approaches to Symptom Management. So biobehavioral clinical research has become my broader focus. And Dean Steiffbergen asked me to talk about my program of research and advancements in measurement and interventions and so on. And so I'll do a broad brush of advancements, touching on my research here and there, and touching on advancements in measurement and advancements in interpretation, advancements in theoretical development in this area. Our challenges have been many in the last couple of decades. In the last 10 years, though, we've made great progress in defining, through our research, in defining the mechanisms of biobehavioral phenomena, and in that same time period, in part because of our research, but largely the basic scientists, immunologists, for example, have greatly expanded our understanding of immunology. So each time I look up, they've named a new cell or a new cytokine, and it's still difficult for me to keep up with. What is the latest cytokine? I think there are 27. Where are you, Dr. Ruiz? IL-27 or something like that. I think, isn't that enough? You know, stop. But we are dealing with a very complex area of science, and of course, nursing science always deals with very complex phenomena. So. These are the things I will touch on. I'm going to back up and talk a bit about biobehavioral clinical research, and then we'll come back around to some of the specifics of the complexity in this area. I think it's fruitful to start with how did we get to psychoneuroimmunology, and how did we get to biobehavioral clinical research? All of these areas are still very much living with us. Many of you know the work of Dr. Hans Selye, the general adaptation syndrome. Dr. Selye's work was first published in 1936, and there's been a tremendous amount of research in the area from his laboratory and others around the world, but we still rely upon that fundamental knowledge of the stress response, the fight or flight syndrome, the general adaptation syndrome that Dr. Selye originally defined for us. In the early 60s, late 50s and early 60s, the psychosocial theorists began developing their notions of how things that happen to us, life events, stimuli, affect us and change our lives. And there are some personality variables, perhaps, that affect our responses to stress. The classic and now somewhat defunct type A behavior pattern. We still talk about the type A behavior pattern, but it wasn't, and in terms of life events, we still talk about very stressful life events change our world, such as on the Holmes and Ray scale, the leading one is death of a spouse, and it gets a score of 100, and if you reach a certain score, you're supposed to be, the theory would tell us you're highly stressed, and we're breaking up here, that we're highly stressed and therefore subject to adverse health events. Those theories are still with us. We still see the Holmes and Ray scale in the newspaper sometimes, in magazines, etc. But scientifically, advancements in cognitive science, cognitive psychology, led us in the mid-'80s. Lazarus and Folkman, Richard Lazarus and Susan Folkman published their now classic textbook regarding stress, and what they taught us, among many other things, is that it's not what happens to us, it's not the life events, it's how we perceive those life events and how we respond to them that determines, or in a complex way determines or leads to our health-related stress response. And then simultaneously, the physiologists, of course, were continuing to do their research. The psychologists were working in here, and never shall the two meet. And Ingalls' biopsychosocial theory that was published in 1977 was a landmark publication of the idea that we're not just biological beings, it's not just our psychological response, we are biopsychosocial beings, and that we should never separate those concepts, that we are, if we have a biological response, there is some psychosocial component. Ingalls' work has been attacked on many fronts, but it still stands, and we still have many biopsychosocial theories that are that lead our research. And some of you may be using those biopsychosocial theories of Ingalls, and in fact, I use tenets of his model as well. But ultimately, we have come to, in my world, we have come to psychoneuroimmunology. I did have to do postdoctoral work in psychoneuroimmunology so that I could learn to pronounce it without stumbling, and now I do it. We usually call it PNI, however, because it's just too many syllables, psychoneuroimmunology. The leaders in the field were, and are, Robert Ader and Nicholas Cohen. In 1975, they made a remarkable discovery, just a paradigm shift. The immune system could be behaviorally conditioned. The immune system could be behaviorally conditioned. So they discovered in murine models with rats, they discovered that they could train rats and mice in such a way that if they were given an immunosuppressive drug and trained and conditioned in a certain paradigm, then ultimately they would also have immunosuppression in response to sugar water. So it was irrefutable at that point that the immune system could be behaviorally conditioned. There was something psychological. I have difficulty knowing if rats have psychological systems, but at least behavioral systems. It's hard for me to know when rats are depressed, but that's just my hang-up. So we know that the immune system was somehow responding to a higher level cognitive learning paradigm at least, and maybe a cognitive paradigm, and it's greatly expanded since this work. So we still rely on the cognitive transactional model of stress. Anyone who works in the biobehavioral field or works with stress theories would readily acknowledge that our various coping mechanisms mediate the effects of psychological distress on psychosocial functioning, quality of life, and physical health. And anyone would readily acknowledge that it's how we respond, it's that appraisal. How do we appraise the stressor and therefore respond? If we appraise something as not stressful, then we will not respond. We will not have a stress response. So that is all readily acknowledged in our field today. The other thing that was happening in the biological realm, I mentioned Ingalls theories. Ingalls theories have been greatly advanced too, and one of the leaders in the field is McEwen. McEwen developed the model of allostasis. He labeled it allostasis. It's not significantly different from what Selye told us in the general adaptation syndrome, but McEwen has developed that model more specifically, more precisely, so that we can measure and perhaps alter allostatic load. And I'm going to talk about that a little bit more. we still do have a great deal of ambiguity in terms of using the word stress. Stress means many things we all probably have a different definition of stress. So if we focus on the biological mediators of adaptation, the current, probably most comprehensive theory is that of McCuen, and he termed it allostasis. The model does recognize that there are individual differences in how we perceive our stressors, environmental stressors. Major life events are part of the model. Those psychologists, Holmes and Ray, who said that things happen to us. And also, this model has a large component of the research has involved trauma and abuse. So those are the context for our developing allostatic load, the concept of adaptive load, moving through a process of allostasis, moving through and hopefully adapting physiologically. This is a physiological model. It acknowledges the psychosocial behavioral response only in word, not in deed. It is a physiologic model. Is this a familiar model to most of you, allostasis? It's becoming more popular in nursing research and has some really nice advantages in terms of measurement and research advancement. The general biobehavioral model, though, I think is better represented. I don't know why I keep making those funny noises up here. Sorry, and my apologies to the sound technician. And the video technician will cut this part out, I'm sure. Yes. I was talking about the general biobehavioral model. Where was I? I think this simple diagram better represents our complexity. We have any number of cofactors, antecedents, things that happen to us, trauma in our childhood, abuse in our current situation, psychological or physical abuse, any number of things that come in as cofactors, antecedents. And then there are any number of moderators, which include our coping responses, our social support, our resilience, our hardiness. Many of those psychological concepts would feed into here. And physiological mediators, which I will talk more about, that interact to produce a certain outcome. We can measure various aspects of this whole process. We can choose what to measure in this whole process. We can measure immunological mediators. We can measure coping and social support. All of these are biobehavioral measures. And we're getting very complex and sophisticated in our ability to measure those aspects of this model. And of course, health outcomes. We're very sophisticated in measuring health outcomes. We can measure allostatic load with some precision. All of the indicators that you think about in terms of health status have become very sophisticated. This is essentially, I'll say it's my model because my name comes first, but I have always worked with very sophisticated and gifted scientists, so a number of us have developed this model over time. This model is, our psychoneuroimmunology model says that yes, we acknowledge and that these person-environment transactions are critical to the interaction of behavioral and biological cofactors. In this particular model, we are focused on illness. We are focused on moderators, including and particularly biobehavioral interventions, and mediators, including and particularly stress coping, cognitive function, social support, as well as our particular interest in my research program and those of my colleagues currently is in the neurological and immunological mediation of this process. So the stress process is represented here as a more holistic view of the stress models that led us to this point. You know, I could entertain questions during the time. It's up to you. If you have a question, I'm happy to take it. But we have some discussion time afterwards as well. So we come to P&I, and let's just define P&I, psychoneuroimmunology, and we'll call it P&I because of its syllabic complexity. Did I say that right? Syllabic complexity. Yeah, thank you. For me, it's an inherently holistic biobehavioral model. Holistic because if you say psychoneuroimmunology, if you say that you are using that model, you are obligated to consider the various components of the model, including the psychosocial aspects of leading to disease and involved in responses to disease. So it's a very effective model for integrating all of those various processes, psychosocial, biobehavioral, pathophysiological processes that are involved in numerous stress-disease relationships. What happens to us? What does life do to us? We term that stress, and so stress affects our health status. We all know that. We don't know as well how to intervene in the process. We've learned a great deal, but not enough just yet. So we are concerned with primarily the neuroendocrine immune system interactions in terms of the biological component. Because of the nature of these mechanisms, we tend to focus on immunologically mediated diseases and immunologically moderated diseases, simply because those are the ones which we find to be, that's the vulnerable populations. Those are the vulnerable populations. Those who have immunologically mediated diseases, people with HIV infection, and those who have or are at risk for immunologically moderated diseases such as cancer. What we've learned over the years is that virtually anything that can be labeled psychological distress, whether we measure depression or negative affect or grief or loss, psychosocial phenomena of distress, that distress, as well as, in addition to, perceived loss of personal control, both those factors almost invariably lead to immunosuppression. So we've been able to narrow down whatever we measure, if it's a concept of psychological distress or loss of personal control. Illness-related uncertainty, Dr. Michelle's work is leading us in this same direction. She's now involved in P&I research as well, lead to immunosuppression. So we could talk about a number of concepts, but they all converge on this physiological process, which, of course, is a normal process. This is a normal process. Dr. Selye in 1936 was so bold as to say we can't live without stress, and he meant it literally. We cannot live without stress because if we don't adapt, then it's our adaptive mechanisms which in part keep us alive. So whatever we define as psychological distress or personal loss of control causes a physiological response, and that physiologic response normally involves stimulation of the hypothalamic pituitary adrenocortical system, speaking of syllabic complexity, and we call that the HPA system. The HPA system is responsible for elaborating a number of neurohormones, neuroendocrine hormones, including corticotropin, endorphins and cortisol. Simultaneously, the sympathetic adrenomedullary system, the sympathetic nervous system, and in concert with the adrenal medullary gland, the SAM system, elaborates epinephrine, norepinephrine, and enkephalins. These processes are going on simultaneously. This is a complex system, but in addition, in the last decade, perhaps longer now, we have discovered, we being immunologists, not myself, have discovered that immune cells have specific receptors for any number of neurotransmitters, neuroendocrine hormones, any number, quite a number of receptors for these hormones. And so fundamentally, if we, and this is greatly oversimplified, but any substance, any protein, any transmitter which has a cellular receptor, that cell is going to respond. So immune cells have receptors for cortisol in the human being. And so those cells respond through their receptor mechanism. And what we've discovered we now call immunological pleiotropism. Pleiotropism being the idea that there are multiple innumerable receptors and innumerable responses and directions to that response. At the same time, we now know that these lymphocytes, white blood cells, produce neurotransmitters and neurohormones such as ACTH, corticotropin, interleukin-1 and beta-endorphin. The cells produce those substances, and they're biochemically indistinguishable from the central nervous system or other sources that we knew. The hypothalamic hormones, these are indistinguishable biochemically. So they're the same substance. The immune cells are producing these same substances. I've just started calling that neuroendocrine pleiotropism, neuroendocrine complexity, because the cells of the immune system, the cells of fat tissue, we were talking about adipose tissue producing adiponectin, those sorts of things, they're all interacting simultaneously to control the immune system as well as our health outcomes. So we're back to a bit simpler model of psychoneuroimmunology, and I think it boils down to this. We must consider the cognitive transactional model, psychosocial factors and how we respond to them, as well as the traditional biobehavioral models. And we can combine that into psychoneuroimmunology if we look at the spectrum from perceived stress and the context of that perceived stress, social support, environment, culture. Perceived stress causes neuroendocrine responses which interact in complex ways with the immune system. One of the factors most studied, we know the most about cortisol at this point. So we tend to measure it a lot. We know what it does. So we can say right now it's one of the most important factors. The truth is that we know the most about it. There may be other factors more important, but we know a lot about cortisol. So in this process, for chronic stress, in states of chronic stress or extreme stress, cortisol is elevated such that it results in immunosuppression. So for newspaper articles, magazine articles, we could say this would be our model of psychoneuroimmunology. Stress causes health problems because of these mechanisms. So if we can intervene in any part of this model, we can improve health outcomes. The immunosuppressive effects of cortisol I mentioned very briefly, but to remind us all of the immunological pleiotropism, if you will. A reduction in the numbers and function of immune cells, primarily T lymphocytes, monocytes, and natural killer cells. What else is there? Well, there are a few other cell types, but those are the critical cell types for both humoral and cellular immunity. And it causes inhibition of cytokines, particularly interleukin-2 and interferon gamma. Interleukin-2, IL-2, and interferon gamma have been shown to interfere with virtually all components of the immune system. Virtually all components of the immune system. So if you've changed the physiologic pattern of cytokines, excuse me, then you're going to change the pattern of the immune response. So this is the result of stress. We end up with more cortisol than is elevated cortisol beyond the biofeedback mechanism that would normally reduce that level of cortisol. And so we can say in summary that stress suppresses type 1 cytokine activity. Type 1 cytokine activity means those cytokines that downregulate cellular immunity. And at the same time, it enhances type 2 cytokine activity. Type 2 cytokine activity includes those cytokines which augment humoral immune responses. So augmenting humoral immune responses, antibody reactions, antibody production, think about that in the sense of chronic inflammatory diseases, chronic fatigue syndrome, arthritis. So we're enhancing immune function in the sense of humoral activity. So either way, it's bad. I have a colleague that says it's bad. It is bad for your health. And you might ask, how bad is it? Well, it can be very bad, but we can also intervene. As nurse scientists and nurse practitioners, there are a number of biobehavioral intervention strategies that can be part of our independent practice and should be, in my opinion. Stress management strategies, it's fairly easy to learn techniques to help people relax, whether that's traditional relaxation, general muscle relaxation, or using techniques such as guided imagery, biofeedback, and we have done a lot of work with Tai Chi. Tai Chi training has been very effective in this area, and I'll be able to talk to you a bit more about that as well. And we generally find, we and others generally find positive immunological changes. But we need a great deal more research. We need to be able to modify this process at any number of points, at any number of entry points within that psychoneuroimmunology model. We could potentially alter the outcomes in a positive way. So I wanted to talk a bit about my research program and how we've come to understand some of these mechanisms. It's very brief, and the sound technician's going to cut me off if I get to. I think that might be my device here that's interfering with the sound, but whatever. You're okay, right? I'm okay. We're good. So much for the CD. I didn't want it anyway. You'll cut that part out too. Yes, thank you. Where's Lindsay? She is just so embarrassed with me talking like this. Not to mention the dean. Okay, where was I, Sharon? I was talking about my research program. My research program has been focused on stress, as I said earlier, and psychoneuroimmunology. We've had a number of And again, let me say that my colleagues have been very much a part of this progress. I feel very fortunate that my name is associated with this work, but I certainly could not have done any of it without my colleagues, and they have contributed in immeasurable ways to all of these studies. So the first one I'll mention was funded by NINR, I believe it was 1996 to 2000, and we looked at traditional social support groups and cognitive behavioral relaxation training in people with HIV disease. We'll come back. The next study, we found that traditional social support groups were not as effective as cognitive behavioral relaxation training, so this was the point at which we switched to less traditional, and at that time they were called alternative stress management interventions, and we started the Tai Chi Training as well as spiritual growth groups in this study of people with HIV disease. Well, NINR was less interested, and so the National Center for Complementary and Alternative Medicine picked this one up, and so we continued the research. Just a glimpse at what we do with our interventions. Cognitive behavioral stress management. There are innumerable approaches to cognitive behavioral stress management. We have our own standardized approach and training techniques for muscle relaxation, guided imagery, beginning meditation, and a number of individualized strategies. By individualized strategies in this study, we taught a number of approaches to cognitive behavioral relaxation, and then at the end of the intervention period, we worked with the individuals to try to design stress management programs that were cognitive behavioral programs that were best for them, that worked best for them. People don't like the same thing. Some people like the progressive muscle relaxation and some people like imagery. So we worked with them to individualize that. Long story told short, it didn't make much difference whether we individualized them or not. So we are still teaching the same sort of general approach to cognitive behavioral stress management, and people choose what they like. So they're very capable of choosing what they like. We also talk about active coping strategies, and we have a series of tapes to help the individuals with guided practice. We introduced focused Tai Chi training, and my colleague, Dr. Lynn Robbins, developed a beautiful program for focused Tai Chi, and it has become very popular and very meaningful. It is a short form of Tai Chi and involves specific movements that we have selected for their particular meaning. So, as I said, it's a beautiful program, and Dr. Robbins is now using that training with other individuals, other groups in her own research. Videotapes, CDs are available. We also used spiritual growth groups. Some of you may know the work of Inez Tuck, my colleague. She designed a spiritual growth group, and she has published, there are several publications related to this, but it's designed for personal sharing and communal exchange related to one's spiritual being, not religion, but one's inner spirit. And the intervention assists individuals to explore their own meaning of that spiritual essence and enhance their individual awareness of spiritual essence. So it's not an imposition. We do not impose our beliefs about what spiritual is. We assist individuals to explore and come to value and more meaningfully use, if you will, the strength, their inner strength. So this intervention has also been quite broadly distributed now. I won't bore you with too many interesting results, but what this slide shows is that the FAAN is a quality of life instrument for people with HIV disease. The functional assessment of HIV infection is a multidimensional quality of life instrument. So what we found was in all 3 intervention groups are in color, in comparison to the randomized control group, the intervention groups had elevated quality of life, and it remained elevated at a 6-month follow-up in comparison to the control group. So they felt better, they thought their quality of life was improved. But perhaps most importantly in terms of the science of psychoneuroimmunology, we also saw that in all 3 groups, and to our knowledge, this is the first publication, this is the first finding of psychosocial interventions enhancing lymphocyte proliferation. The actual function of lymphocytes undeniably increased in the 3 intervention groups. Now they have HIV disease, so without the intervention, their lymphocyte function, the control group, declined over time. This is a 6-month time period. So we have shown that these biobehavioral interventions enhance immune functioning in this population. So the enhanced lymphocyte functioning, functional measures in HIV disease are early indicators of disease progress. So it's important that we saw those functional increases as opposed to increases in CD4 cell counts, for example. The functional changes are earlier in the disease trajectory, earlier biomarkers, if you will. So just a summary of what I've been telling you about our interventions. Our first interventions, traditional social support, didn't work as effectively as it didn't have, I shouldn't be quite so colloquial, quality of life and satisfaction with the intervention was not as high as with relaxation training. That may be in part because this was a time in history when people with HIV disease, they didn't particularly want to spend time in groups talking about how sad they were and how terrible this was. So it's part of the, there's always the context. There's always the environment and always the interaction of the individual's perception with the environment. So this was a developing time in the disease treatment, and they didn't care for the social support groups, we believe. The next group, we saw some psychosocial changes, which I've shown to you, and the Tai Chi was found to be most effective. It had the most dramatic changes, and it was the most popular. It wasn't randomized. These were randomized controlled trials, and so people did not get to select their groups, but they were often disappointed that they didn't have the Tai Chi group. Our current study is funded by the National Cancer Institute, and we're doing these same types of alternative strategies, that being Tai Chi and spiritual growth groups in women with breast cancer. The same collaborators you noticed, Dr. Robbins is still doing Tai Chi, and this Tai Chi has been focused for this group of participants. It's focused on the experience of being treated for breast cancer. And the spiritual growth group as well is focused on that experience. I wanted to show you on this slide that we're measuring the same types of biological cofactors, health status, cancer stage, etc. You have to have that foundation, what's going on biologically, psychosocially, and then that foundation, we believe, that interacts in a critical way during the period of chemotherapy. We're looking at the biobehavioral interventions of Tai Chi and social support. We believe it's changing both, or potentially changing. We don't have results, our complete results yet. Perceived stress and coping patterns. We remain interested in neuroendocrine mediators, but we've advanced. We're now able to measure things that we did not measure in the earlier studies. Still looking at immunological mediators and cytokine patterns. We have the 10-week interventions, and we're following this group for 2 years. We are closed for enrollment, but we have not completed the follow-up as yet. What we are seeing, though, in our preliminary analysis, this is the same time 1, time 2. It's a 10-week intervention, pre-intervention, post-intervention. The pre-intervention is before they start chemotherapy. Post-intervention is about 4 months, 6 months later. So what we're seeing here in this particular slide, no intervention, the control group, the usual care group is in red. So here we're seeing the endorphins. There have been very few reports of endorphins, and we're seeing the endorphin levels in both our intervention groups are increasing. And they remain stable, much higher than, well, significantly higher at 6 months than the control group. So again, we're showing that these biobehavioral interventions, nursing interventions, can change the physiology of the immune system. And we have not completed the analysis for our health outcomes, but we believe elevated endorphin, the same thing happens with the enkephalins. The same thing happens with the enkephalins. You have the same pattern. The control group goes down, both intervention groups go up. We believe that that's positive. The endogenous opioids, both of these are endogenous opioids, are generally found to have positive effects on immunology in physiologic doses. There's a dose-response curve such that if they're very high, as in extreme runners, sometimes as in, I started to say drug users, but that's not endogenous opioid, that's exogenous opioid. But extreme runners sometimes can have this dose-response curve where they have positive responses and then they decline. So, where are we? I think I have discussed this. We are still looking at these, what used to be called alternative interventions. The National the National Center for Complementary and Alternative Health doesn't consider them alternative anymore. They're becoming more mainstream. So many people are testing Tai Chi in particular in various groups across the country. What we believe, actually, what we're learning probably most importantly with our women with breast cancer is that we need to be testing interventions at various times during the disease trajectory. We intentionally chose perhaps the most difficult time during the experience of these women, and that was when they were actually receiving chemotherapy. They all received chemotherapy. Some of them went on to receive radiation, but we intervened during that period of time. And our psychosocial outcomes are not what we expected. Similar to the social support groups, actually. Quality of life with the Tai Chi group has gone down at the end of the intervention. We believe that part of that is because we have intervened during a critical period. They do have very positive qualitative responses to the intervention, and they have positive physiologic responses, but then we leave them. Their Tai Chi trainer, who has become very close to them, their spiritual growth group leader has become very close to them, we stop our interventions. So we are seeing them come back. Their quality of life doesn't stay down, thank goodness. I wouldn't want to report that to NCI. There's just the dip at the end of intervention, and then they come back up. So the quality of life scores are coming back up the post-intervention. So, but we need to test interventions at other times during the disease trajectory. There are many intervention studies that still need to be done. So the doctoral students are hiding on the back row if they've not decided. There are many, many studies that need to be done in this area. We now have a Center for Biobehavioral Clinical Research. We started with what's called a developmental center, and we now have a P30 center as the same mechanism as Dr. Steifbergen's P30 center here, the Center for Health Promotion. Ours is focused on biobehavioral approaches to symptom management. So we're continuing to study these complex areas of measurement and intervention in various populations. So here I'll get involved a little bit with some of the complexity and some of the measurement issues and some of the analysis issues. It'll be a brief tour through Disney World, if you will. Brief tour through Disney World? Yes. We're focusing on a number of, in the centers, we focused on different populations, but we're all focused on biobehavioral outcomes, biobehavioral variables, that biobehavioral model that you saw earlier. We have very complex data sets sometimes. Well, all of us have very complex data sets. For example, one of my colleagues, two of my colleagues, Dr. Grapp, Mary Jo Grapp and Cindy Monroe, if you know critical care and you know ventilator-associated pneumonia, you know who they are. They have massive complexity in their physiologic monitoring data. And it's requiring our biomedical engineers and our best computer engineers and computer scientists and our best information technologists to try to put all of this data together. So we have very complex data. Because of this complexity, we're able to measure, I will be so bold as to say, we can measure beyond our ability to interpret. We can measure many aspects of biobehavioral phenomena. But then when we try to interpret them, when we measure and we have this massive empirical data before us, it's very difficult to interpret. So we're in the era of complex analytic and interpretive approaches as well. It's not only the complex measurement, but what do you do with it then, and what does it mean? We are measuring numerous aspects of autonomic and CNS function, cytokines, etc. I think I've talked enough about complexity in P&I, I would think, yes. In P&I, many of us are interested in measuring the cytokines because those proteins are so critical to immune function. We used to have only singular markers of cytokines, so we could measure 1 or 2, possibly 3 cytokines that we selected. One of your colleagues is measuring, I think, IL-6, IL-10, and TNF-alpha. Dr. Fowles there, because she had to select those markers because of the technologic limitations of measuring them. She now has the ability to, because you now have a multiplex platform, a bioplex system that can measure theoretically up to 100 analytes in a single run in a single well. So you can easily measure very quickly in an automated, precise fashion. You can measure, we're measuring 17 cytokines as a rule, sometimes 27, but 17 as a rule. And we are able then, with this new technology, we are able to look at the patterns of those cytokines and talk about type 1, type 2, the cellular immunity, the humoral immunity, the type 17, which is a fairly new introduction from the immunologist, and as well as the T-regulatory immune proteins. So with that panel, because we can measure it, we have extensive information on this pattern of cytokines. We don't quite know what it means, but and the reason we don't know what it means is because there's been little research before us. We are, those of us in P&I who are nurse scientists, are very often leading the way in looking at these complex models. We have basic science colleagues who are looking at the functions of IL-2 on a certain type of cell in a, it's probably not a petri dish, but the point is this little cell under a microscope, we can now look at real-life situations, people who have breast cancer, people who have preterm infants, and look at this pattern of this in vivo pattern of what's really going on there. And when we do that, we have very complex data sets. We will be able to interpret them, and as we continue to publish, and researchers over the country, international researchers, begin to publish the patterns that they're discovering in certain disease types, maybe we'll be able to define patterns for a certain disease and see how those patterns may change over time. And this is just using the illustration of cytokines. I had planned to talk with you about cortisol, but most of you have a really tight handle on salivary cortisol in particular. The normal pattern of cortisol, when we first wake up in the morning, here you have the time, it's 7 a.m. So if you have a normal sleeping pattern, you first wake up, the level of cortisol in the saliva is relatively low. 30 minutes later, it peaks. It peaks at 30 minutes because it has a lag response time of 30 to 45 minutes. So what's happening right here 30 minutes after awakening is in response to having to get out of your nice warm bed. There is a 30 to 45 minute lag time, and it's always seen very beautifully here on these types of 24-hour plots. And then it levels off throughout the day. Around noon, at least by 2 o'clock, then you have a fairly low level and a stable pattern until bedtime, and then it declines and goes back up. So because of that, salivary cortisol, if you're measuring the slope, you have to have multiple salivary samples over the day, or the pattern. If you want a total level over 24 hours, you have to have urine samples, 24-hour urine samples, which are very difficult to collect in the community, as you probably know. They're difficult to collect in the hospital environment, so there you have it. If you want peak levels, you have to look at 30 minutes after awakening. And sometimes we have to use serum sampling. We have to use indwelling catheters if we want serial measures for serum sampling. And don't forget that time-lagged response. I think we've been slack in our interpretation in that regard. Endogenous opioids, as I've been talking to you about endorphin and epinephrine, they're very widely distributed. They have very intriguing and important effects in down-regulating neuroendocrine and autonomic stress responses. So in contrast to the cortisol, those endogenous opioids are down-regulating the stress response. They're difficult to sample because they degrade so quickly. So you have to sample them, if you're drawing a serum level, and that's the only way we can measure them at the moment. I'm sorry, you can measure them in urine as well, but the most effective way is in serum samples, and we have to stop their degradation immediately with a protease inhibitor in the vacutainer, and we have to process them immediately. So that's if you're using serum samples. And there are very little data to compare our findings to, so this needs to grow as well. I'm going to skip alpha amylase, except to show you that salivary alpha amylase is becoming a very popular marker because it's co-regulated with the autonomic nervous system. Co-regulated. So the regulation of the autonomic nervous system mirrors that of salivary alpha amylase. And you'll note here that salivary alpha amylase is the pattern of circadian secretion or production is opposite that of cortisol. Opposite that of cortisol, which is what you would expect if you think about the mechanisms of the HPA axis and the sympathetic adrenomedullary axis. So this is becoming a pretty popular measure. Catecholamines, you know what I want to show you here on cytokine patterns. I hid those slides. This is what I want to show you. I was supposed to hide all those slides in between. I think that's Lindsay's fault. Lindsay. What we're looking at in cytokine patterns, this is a profile plot of the 17 cytokines that we currently measure. They're measured in picograms per milliliter, so they're very precise, very accurate measures, and this is from our Bioplex data, and this is how one way that we show patterns in our cytokine data. Each line there is an individual patient. So we have this sample of 305 people with HIV disease. Each line is an individual patient. But you see here, you can see patterns there where things spike. Interferon gamma clearly spikes in this population. Some of the growth factors are spiking here. Down here, you're seeing very low levels of some cytokines. Okay, compare that then to this breast sample of people with breast cancer. This is on the same scale. Same scale. You have spikes here up to 170,000, 300,000 picograms per milliliter in the HIV sample. Here with the breast cancer sample, nothing like that. They are actively being immunosuppressed. Actively immunosuppressed. Now you do get a little different picture when you blow up the scale here, and this is the same data as there. This is the same scale for HIV breast cancer. And then if you blow up the scale there and look at just the lower level, you can indeed see that in this, while on the bigger scale it looks like there's no fluctuation, there's no pattern. There is, in fact, a pattern. And 100 to 200 to 300 picograms per milliliter is a very small amount, but physiologically, it's enough change to make a difference in the immune system. So physiologically important changes are going on here. And again, we see the patterns in this one that are very different from people with HIV disease. They're tending to cluster in different patterns. So this is the kind of work that challenges us all in biobehavioral clinical research. We have made great advancements in our ability to measure. We've made advancements in our ability to intervene and treat people who are suffering from stress responses or chronic stress, including illness. Illness is a chronic stressor. But we have a great deal more to learn about interpreting, integrating our findings in such a way that we can then say women with breast cancer have dampened type 17 cytokine patterns that result in fatigue. I made that up. I don't know that. But that's the kind of information that we need. Women being treated with chemotherapy for breast cancer have dampened type 17 cytokine patterns that cause fatigue. That's the kind of knowledge we're looking for. I wish I knew what caused fatigue. I'd be wealthier than I am. Many of us are looking at symptom clusters, symptom management, and symptom clusters. We know that these symptoms co-occur: depression, fatigue, the things we call sickness behavior. Is that a familiar concept? But we don't know why yet. There are also genomic studies going on in this area. Is there a polymorphism in the IL-17 gene that causes fatigue? I'm making that up too. But that's the kind of question we're faced with. What's going on here? We now have the capability of analyzing or measuring. Now we need to move forward with our understanding. So it's a very challenging field, and I invite you all to join us in the in the search for those markers, biomarkers, and interventions. So I believe we do have some set aside time for questions. Yeah, it's good.
Have you entertained the thought of what, for instance, triple negative breast cancer patients can do after initial treatment? Positive hormone therapy is done. There's nothing that can be done for triple negatives.
Right.
So my question is, you know, what do those patients do in their future?
In their recovery, yes.
To prevent recurrence.
Yes. Well, that's a very important. Yes, the question is related to what do we do then as we learn about genomic profiles or phenotypes. We know a fair amount about different types of breast cancer, and the question from Dr. Presson was, if you have triple negative markers in breast cancer, hormones are not indicated. And the question is, what can that woman do? What can she do to possibly prevent reoccurrence? Well, I don't know, but that's a very fertile ground for looking at the period after initial mastectomy and treatment. And would the behaviors, or does the stress level affect the recovery? I'm sure it does. And I'm sure women who are treated for breast cancer, as many of you would know, you know, you're treated for breast cancer and they say, okay, you can go home now. Well, it doesn't go away like that, not with any cancer diagnosis. You know, there's always this threat with you of, well, it's not gone away, they didn't get it all and it's going to come back. So there's a great fear and discomfort. And can we, as neuroscientists, intervene during that period? Yes, we can and we should. And if we look at some genomic changes during that period of time, as well as immune system functioning, including natural killer cells, which are critical in cancer, natural killer cells are able to destroy cancerous cells. That's our primary initial response to abnormal cells. And if we can enhance lymphocyte proliferation with Tai Chi, I'm sure we're also enhancing natural killer cell function. So yes, we probably could someday make the case that our interventions would enhance or improve survival. Survival, not just quality of life. Yes? Right.
You know, in my sample, where I'm looking at heart failure patients, they don't all have the exact same dosage, they don't have the same BMI, and the question comes, well, how do you know that your dosage isn't effective for immune response?
Yes, that's a very important question, and once again, I can't give you an easy answer. In our studies, in most clinical trials, randomized clinical trials, you have to restrict your sample. So in our studies, the women have only stage 1 or stage 2 breast cancer, of which they've had a simple or modified mastectomy or lumpectomy, and they're treated with, they used to be treated with the ACT, adriamycin, and the so their chemotherapy regimens were controlled to the extent that we could. Now, because those medications are such a tremendous confounding factor in our research models, we have to be able to at least monitor. If we can't control that regimen, you have to at least monitor any changes in that regimen. In HIV disease, our studies were going on during the time that protease inhibitors were first introduced. My first studies were before AZT was introduced. So I've been through the gamut of that, and the periods of time where there were rapid changes in treatment protocols. The decision we made, my colleagues and I decided that we had to, if we were going to have valid outcomes, we had to drop those immune measures for those persons who had dramatic changes in their medications. And I think that that's about the only way we can control it. We don't wish to control their medication regimens. We're not suggesting that. But I think our science does rely on our good judgment of when to withdraw the patient from analysis. So it's a very good question. And it would be true of any disease. People are not treated the same. They have different regimens. I think you had to, yes.
Looking specifically at your most recent study with the breast cancer population, you showed on your charts there that there was a significant increase between time point 1 and 2 on both charts with your
With the opioids,
with the spiritual intervention versus even Tai Chi, but then between points 2 and 3, significant fall off. But Tai Chi seemed to be more, I guess, slow and steady. Have y'all thought at all, or in putting into as you're writing up as you wrote your discussions about this, or you're thinking about this, looked into what factors might be included in that? Is it perhaps the physical side of Tai Chi that's also in there that the spiritual does not include, perhaps, or what might be causing that?
That's a wonderful question. I wish somebody would ask a question I can actually answer. That would be nice.
If I might add with that, what's going on between time points 2 and 3?
These slides you're talking about.
Yes.
Well, what we see here is that your point is very well made, that the change between the groups is not significant. Now, when this is adjusted with multivariate analysis, the baseline has to be adjusted so that they're all equivalent. So the change between the groups is not significant statistically. But indeed, it does look different. And are there physical reasons? Probably. The Tai Chi group also had less withdrawal. And there was differential withdrawal in the spiritual group, such that people who were more distressed tended to drop out. So we have all sorts of confounds in these data. And I appreciate your comment, because that's really some of the interpretation that we're trying to struggle with. Now, what we interpret here is this is actually probably return to normal. This is probably a return to normal level, but we don't know that. We don't have the comparative data to say that. But we think we're seeing an enhancement during the intervention, and then it's returning to normal 6 months later. But in these people who have not learned different coping strategies, they don't have, it's continuing to decline. So I think the interventions are very much different, and we will ultimately have to do studies to decompose the various effects if we care to examine particulars of those interventions. I don't know who was next. Dr. Walker? Yes. Yeah, we don't do anything. We don't do anything because we do not wish to interfere with what they would normally undertake. So if they join an exercise group, we take note of it. If they read a book about Tai Chi, we take note of it. But we do not ask them to abstain from any health behavior. So it is a confounding factor. There was another question in there. Oh, to retain the control group? Yes, that's important. How do you retain your control group in any study? in this particular population, once they agree to participate in the study, they're fairly committed. So actually the control group was easier to retain than the intervention groups, because the intervention groups, even though they liked Tai Chi, they were not feeling well and they didn't feel like getting up and going to group once a week. So we didn't have differential withdrawal in that sense in this population. Now, other populations, not necessarily so. It's just your charm in explaining how science is going to help them or help others in similar conditions. But problem. If in my world, if I had made that discovery and become wealthy, I would try to change NIH such that we can actually do individualized interventions and get funded for it, so that we don't have to assign people to control groups, that we can ask them, what would you prefer to do? And then we do that. I'm not going to be around long enough to see it, but that was my dream at one point. Because, people should be able to choose what suits them, what's their style. I think that's why we have differential withdrawal from the spiritual growth group. There was another question in this area. Yes?
I just wanted clarification on that slide when you said the time 3 may have been an indication of a return to normal.
Uh-huh.
That was the word, return to normal.
Uh-huh.
Is that the individual's normal before the diagnosis of cancer? Is that what you meant by that?
Possibly. We don't have those measures, but possibly, yes. Possibly they're coming back. Wouldn't it? Yeah. Yeah, we don't have those data. So, again, it's a long process. Good question. More questions? Yes?
I'm wondering, back to the Tai Chi intervention, particularly for these folks, did you have anybody that was not able to do the Tai Chi?
Yes, at times. Yeah, they have 10 weeks of group intervention, and yes, sometimes the women participated only by sitting and being with the group. They have DVDs which are given to them, and so they watch the poses. They're with the group, but yes, we had people to sit through them, and then report to us that they practiced later. The way the Tai Chi groups, the intervention is set up, the movements build toward a final form, if you will. So they're learning a form, which includes embrace tiger, return to mountain, those types of things, if you know Tai Chi. But they're learning this form. So if they missed a week and they didn't practice with the group, then ultimately most of them caught up with the group.
I have a question.
Yes?
On your slide with the cortisol pattern,
Yes?
is it different for people who are night owls? Does that...
Oh, yes. The cortisol pattern, is it different for people who are night owls? Yes, that slide you saw on the cortisol pattern is predicated on what we call a normal sleep pattern. And that's actually normal for adults who are not in school. So, yes, if you change your circadian cycle, if you change your sleep pattern, you are definitely changing your cortisol pattern, which may or may not be healthy. So we're beginning to worry about all those adolescents who don't sleep, and shift workers who work at night. Unless they maintain that pattern, I mean, you can maintain an opposite pattern and be fine, but switching back and forth is not so healthy for many reasons. So. Yes?
Besides nursing, are there other fields that are doing research similar to yours?
Besides nursing, are there other fields doing similar research? No. Yeah. Just kidding. I'm just kidding. I am familiar with the other disciplines. Psychoneuroimmunology is a transdisciplinary field. We have our most notable organization is the P&I Research Society. Most of the members, the vast majority of those members, are basic scientists. They're immunologists, they're microbiologists, they're biochemists. And so they're doing basic research in this area. There also are a number of psychologists and even sociologists and epidemiologists involved in this kind of work. So the other point that I have the opportunity to make, and thank you for your question, is that this type of research requires multidisciplinary teams. So I think we as nurse scientists have a broad, holistic view of this that's very valuable to the field, but we don't have, no discipline has all of the knowledge required in a complex model like this. So we work with multidisciplinary teams. I have an immunologist on my research team, and physicians, biostatisticians, biomedical engineers to help us interpret these data. So I think the other part of your question, are they finding similar things? Yes, much of what I summarized in the beginning is a summary from a couple of decades of research in psychoneuroimmunology. There are a number of leaders in the field outside of nursing. Yes?
Along that same line, what advice would you give to, say, a beginning master's MSN student to, in terms of a program of study, to become a P&I scientist?
A master's graduate? Is that?
Because a lot of these are master's
Yes. Well, let's see, if you want to come to the Virginia Commonwealth, no. Sure. Well, we have in our doctoral program, we do have biobehavioral clinical research as our singular focus area. So we do nursing theory and theory development, knowledge development, quantitative and qualitative research, but our substantive area is biobehavioral clinical research. I would advise, now master's graduates can certainly become involved there. There's a fair amount of literature. There are some textbooks. There are a number of reviews of the field. And master's graduates could readily become involved by collaborating with some of you. You have several scientists here who are doing P&I related research. You could collaborate. You can develop new interventions and as long as you're measuring some psychosocial component, behavioral component as well as a biological component, you're involved in this area of research. As far as P&I itself, there is no degree in P&I because it is so multidisciplinary. So you choose to study in the field. There are a very limited number of postdocs in P&I around the country. So you could locate one of those. They're very competitive, but work with some of the scientists who are doing this research. I'm wanting to say that baccalaureate graduates are involved too, because stress management as a skill is part of what we do. We help people. We are there for people. We listen to people. We care for people. We help them cope with stress. So you are involved in psychoneuroimmunology and biobehavioral science. You may not be conducting the research, but your nursing care makes a difference. And so we're all involved to some degree. Thank you. Thank you.
Dr. McCain.
Yes, ma'am.
My name is Andrea Brannon. I'm the Director of Development for the School of Nursing, and you're probably wondering why is a fundraiser now getting up here and taking the microphone? You're not even a nurse.
Virginia Commonwealth University takes all my money.
Well, I'll talk to you about that later.
Okay.
But the reason that I'm here now to thank Dr. McCain is to let you all know a couple of things. First of all, how much we appreciate your willingness to come and spend your day with us and provide this information. As someone who is not a nurse, I actually enjoy coming to these because I feel like I learn just a little bit in each lecture that I can, hopefully speak a little bit more intelligently to the faculty or the students. Like I don't have a deer in the headlight look anymore. I hope that's coming across. Anyway, we appreciate you coming.
That's my pleasure.
We have a small token of appreciation for you, and we would like to present this to you now.
Well, thank you, thank you. Look at that, a small token. Ah, it's not so small.
Not so small. We'll be happy to ship that for you if you don't want to take it on the plane.
May I open it now?
You may open it now.
I may open it now. It's what's that? Oh, should I not open it now?
Oh no, you can open it.
Okay. Well, thank you very much.
Sure.
This is what starts here changes the world.
See, you did pick up on that. Yeah,
I am
fundraising
just
talk
so
right there.
impressed. Yes.
The other thing I want to remind you all of is that there is a dessert and fruit reception out in the foyer when we're done, and that none of this would be possible, which is why I'm up here, if it weren't for people who in the past have endowed this lectureship series. So the Jack and Laura Lee Blanton Endowed Lectureship is what brought this presentation to you today. And so of the 6 different lectureships we offer through the School of Nursing, we're always very grateful for the donors who help us to put on these types of presentations. Thank you.
Yes, indeed. And my tribute to you for keeping such activities going. It's important for all of us. So, if they didn't take all my money, I would, where there's a commemoration in London in September. So, I've been to her burial site. I've been to, you knew that, or did you? You didn't. Well, this is very precious to me. So thank you very much. I've got to, do something about this.